Thanks for the wonderful introduction, and I'm happy to be discussing with you today long-acting PrEP and the potential for resistance. Before we jump into the consequences of acquiring HIV on PrEP, I want to start with two very important points. One is that PrEP, especially long-acting PrEP, is highly successful at preventing HIV infection. Second, someone who does not have HIV cannot get drug resistance. This is just a reminder that the fear of resistance should not drive us to restrict access to PrEP. Unfortunately, some individuals do acquire HIV while on long-acting PrEP. There were infections that occurred both in the studies of dapivirine ring and long-acting cabotegravir, and the focus of this presentation will be to better understand what we know about the risk of resistance and how to mitigate it with the rollout of long-acting PrEP. I will first give you an overview of resistance risk with long-acting PrEP, then discuss these risks with dapivirine ring and long-acting cabotegravir, abbreviated CAB-LA. Throughout, I will mention some research gaps and how current implementation studies are working to address these gaps. I'll start by reminding us of what lessons we've learned from over 500 participants from 22 studies of oral tenofovir emtricitabine PrEP. From this table, you can see on the left side that the rate of PrEP-associated resistance defined by mutations K65R, M184V, or K70E is low, around 4 to 7% in individuals who acquire HIV on PrEP. But the rate of resistance is tenfold higher if PrEP was started during undiagnosed acute infection. Rates of resistance from tenofovir emtricitabine PrEP in rollout settings is higher than what was observed in clinical trials. The newest PrEP agent, CAB-LA, belongs to the integrase strand transfer inhibitor class of antiretrovirals, which also include dolutegravir, part of first-line therapy in many countries. The risk of using the same drug classes for both treatment and prevention is that resistance occurring from seroconversion on PrEP could lead to virologic failure of ART, while transmitted resistance from failing ART could lead to breakthrough infection on PrEP. Resistance with HIV acquisition on long-acting PrEP could occur through three major pathways. One is if someone starts PrEP during undetected acute infection. A second is if they continue using PrEP after breakthrough infection before infection is detected. HIV acquisition could occur due to insufficient adherence, and there have been rare cases of breakthrough infection despite sufficient drug levels. PrEP could also fail to protect against a transmitted resistant strain from a partner. So let's dig deeper into each of these cases. Let's first consider dapivirine ring. Dapivirine ring reduced the risk of HIV acquisition among African women in the MTN Aspire and IPM ring phase 3 studies by 30% compared with placebo, and by an estimated 60% in the open label MTN Hope and IPM Dream studies. We saw that the rate of resistance in acutely infected individuals starting oral PrEP was 10 times higher than when infection occurred after starting PrEP. A similar trend was not noted from the dapivirine ring studies, though the numbers were much smaller. Only 11 individuals from the 4 studies were reported to start ring during undetected acute infection, and only one had the mutation E138A, which is considered polymorphic in subtype C for the NNRTI class. Low plasma drug concentrations likely lowered the risk of resistance. In individuals who acquired HIV during the study, the rates of resistance were independent of study arm, suggesting that the resistance noted was likely transmitted and not selected by dapivirine ring. In both studies, the rate of NNRTI resistance was high in the study population of women who seroconverted, 10 to 15%. These rates are consistent with rates reported in the 2021 WHO HIV drug resistance report, where pre-treatment NNRTI resistance is over 25% in several countries. And the rates of NNRTI resistance observed in DREAM and HOPE were similarly high, highlighting the importance of monitoring drug resistance with ring rollout in regions with high background rates of NNRTI pretreatment drug resistance. Now let's turn to CAB-LA. CAB-LA is a potent integrase strand transfer inhibitor, or INSTI, injected every 2 months for HIV prevention. Drug resistance is a concern in breakthrough infections on CAB-LA because dolutegravir, also an INSTI, is a major component of first-line treatment in many countries. The Levi syndrome has also been recently described as a delay in detection of infection in people who acquire HIV on CAB-LA. This delay could lead to accumulation of mutations causing high-level INSTI resistance. In HPTN 083, 4 individuals had started CAB during undetected acute infection. So I'll describe the 4 cases here. Case A1 had transmitted NRTI and NNRTI drug resistance, and case A2 had INSTI mutations detected at seroconversion that were not detected at enrollment, suggesting selection of resistance due to CAB exposure. Case A3 did not have resistance selection, and case A4 could not be sequenced at seroconversion due to low viral load. These sample numbers are too low to draw conclusions, but resistance is likely to be a risk of starting CAB during acute HIV infection. Recently, Marzinki and colleagues updated the HPTN 038 analysis to evaluate the seroconversions in 2 groups. So they divided these into group 1 and group 2, where group 1 included all individuals recently exposed to CAB, and this included people who were HIV positive at enrollment, were in the oral phase infections, infected despite on-time injections, delayed injections, and CAB restarted after injection. So basically collapsing groups that had previously also been analyzed individually. So by contrast, group 2 only included individuals with no recent CAB administration within the last 6 months. There were 2 major findings. One is that INSTI mutations were observed in 56% of individuals who acquired HIV with a recent CAB injection, compared to no individuals without a recent CAB injection. Second, 78% of study participants with a recent CAB injection had delayed detection of seroconversion, compared with 7% without a recent CAB injection. The breakdown of the 10 with major INSTI resistance is summarized in this table. Of note, all 6 individuals who acquired HIV despite on-time injections had HIV with INSTI mutations, and several individuals had multiple accumulation of mutations, 3 or more. And this multiple accumulation is what increases INSTI resistance risk. The rates of pre-treatment INSTI resistance are currently low and unlikely to pose a risk to CAB-LA, less than 0.2% as of 2020, as shown by this analysis from Stanford. Although this image is kind of small, you can see that the percentages are still low amongst most of the positions. Resistance rates could increase with increased use of dolutegravir as first-line therapy, highlighting the importance of having updated pre-treatment drug resistance data that includes INSTI. So to summarize, resistance risk with acquiring HIV on dapivirine is low. This may be due to low systemic drug levels and as shown by equivalent rates of resistance in active and placebo arms of trials. The efficacy of the ring against NNRTI resistant strains is unknown, and this is something that we plan to investigate in Mosaic. The resistance risk with acquiring HIV on CAB-LA is high when HIV diagnosis is delayed. And drug concentrations at the site of transmission may be insufficient to block transmission, but concentrations elsewhere, such as in the blood or lymph nodes, may be sufficient to select resistance. So secondary transmissions have not yet been reported, but will be important to monitor. And finally, all of this does highlight the importance of monitoring for HIV drug resistance with PrEP use. So I'd like to highlight some ongoing work. Mosaic will monitor for HIV drug resistance to understand local rates of resistance in PrEP clients who seroconvert during ring or CAB-LA use. And this will help ensure effectiveness of PrEP programs and to understand if additional support is needed for PrEP adherence and routine HIV testing. And through the ACTION and SeroPrep studies, we are evaluating seroconversions on PrEP to understand causes of infection and follow for 12 months to assess treatment outcomes with PrEP seroconversion. I would like to acknowledge my lab at the University of Pittsburgh, Dr. John Millers and his lab at the University of Pittsburgh, my ACTION co-lead, Dr. Catherine Koss, the Mosaic team, including Christine Torgerson, Jason Reed, and all study team members from many, many studies that whose participants have contributed to this data, including Mosaic, GEMS, HPTN 083, SeroPrep in Action. I'd also like to acknowledge our funders at NIH, USAID, and PEPFAR, and most of all, the individuals who have generously participated in these studies. Thank you all.